Hello.
Hi.
Hello.
Good morning.
Velkommen.
Welcome.
Welcome to UEG Week Virtual 2021.
Whatever your level of expertise, you will find the best and latest updates on UEG Week Virtual.
I wish you those days full of interesting, diverse and creative content.
I count on your contribution and I thank you.
Viel Freude, ingest the best.
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 Keywordは ingest the best です。
Get ready to ingest the best.
Ingest the best.
Ingest the best.
Well, good morning, everyone. If it is indeed morning where you are, and welcome back to our TV studio here in Vienna. My name is Jonathan McCrae, your moderator and host. They say time flies when you're having fun. Well, I can't believe we're at our final day of UEG Week Virtual. I hope you're getting the most out of this experience, exploring the platform, meeting with industry, having a look at the theatre, interacting with other participants and asking questions and getting those burning questions answered by our expert faculty that we bring to you over the course of these days. If you enjoy any of the sessions, please don't forget to rate them. There's a 5-star box underneath each of the sessions. It really helps us understand what is the content that you're looking for and prepare better for next year. So please remember to do that. This is, again, an interactive session. It's live, and we would love to get your questions in the Q&A tool under this video. So get involved and ask your questions of our on-site faculty, who are Professor Herbert Tilk from the UEG Scientific Committee. He's chair, of course. Professor Julia Meyer, who is the chair-elect of the UEG Scientific Committee. Professor Iris Dutton from the Scientific Committee as well. And the chair-elect of the Education Committee, Professor Henrietta Heinrich. You're all very welcome. How are we, Herbert? Good to see you.
Oh, I'm very well.
Look at you. You're all ready to go.
Let's have an excellent final day.
Sure. Well, I will do my best to facilitate you, at least in this session. Yeah. Iris, it's great to have you in studio. This is your first time here. How are you? You feeling well?
I'm great. Thank you so much. It's so wonderful to be here and meet all these nice people and a few dozen others instead of the 15 or 16,000 people that we usually have.
It's very different, isn't it? But it's nice. It's good people. It's good faces. It still feels like an event. And this certainly helps, this lovely studio.
Absolutely.
How are you this morning, Julia?
Well, it's morning, so I'm never very good in mornings, but I'm feeling fine. You make me feel comfortable.
That's right. You are an evening person. I learned last night. We next year we maybe stick like 9 p.m. will be your time to shine. And Henrietta, how are you?
I'm good. I'm also not a morning person, but I think I'll manage. Yes.
A lot of negative energy in the studio here. Wafa Kanusi is chair of the UEG Quality of Care Task Force. Wafa, thanks for joining us. I know you were joining us from your home city because you were having problems with your neck. How are you feeling? Are you feeling any better?
Good morning, Jonathan. Yeah, thank you very much. I'm feeling better.
Excellent. Okay, looking forward to a great session. Your questions underneath the video that you are watching now, please. Let's get started then, if we can. Iris, would you mind please giving us your highlights from the day?
Oh, yesterday was a fantastic day, definitely for us in the lower GI, right? I will specify on IBD and leave something for Julia. So I have an hour and a half, 2 hours for IBD
right.
highlights.
Yeah, exactly.
Right?
The whole day.
Take the day.
Yeah, absolutely. No, I will try to focus on a few issues, but I think that I divided them for of course, the abstracts, the original abstracts, the clinical trials, and the invited presentations that some of them were really fantastic. And I think that the bread and butter, right, Herbert, of what we do is we treat patients. So definitely I think that everyone should go to the clinical late breakers. I think that they were very important yesterday. Of course, we're not going to go into the details, but we had a fantastic faculty. And We mentioned clinical trials in ulcerative colitis, in Crohn's disease, earlier phase and later phase. I just highlighted a few of them. So Laurent Perrine-Biroulet presented the phase 3 upadacitinib studies, of course, with very impressive outcomes for this JAK inhibitor. And of course, people were intrigued whether the good effect for the 30 milligram dose would justify the somewhat higher side effects that were mentioned. And we need new mechanisms of action. So, of course, Séverine Vermeer discussed the oral ABX464. That was an oral medication. That was an earlier phase study. And she mentioned 3 doses, a very nice study with the decrease, significant decrease in the modified Mayo score, again, in patients with ulcerative colitis, telling us that it is still an unmet need to have new mechanisms of action. And I think that we all look forward to see what will happen with this specific mechanism, which is a mere 124 modifier. So I think that was interesting. And of course, going to the Crohn's disease, we didn't neglect Crohn's disease, and Mark Ferrante discussed the risankizumab studies in Crohn's disease, the Fortify, the maintenance outcomes, and showing us the differences between the higher doses and the lower doses, the 360 milligrams and the 180 milligrams, and showing us very good outcomes for the clinical and endoscopic remission at week 52.
Great.
So, yeah, I think that this is important and encouraging. Actually, I think that what was specific, I will not forget the other abstract presenters, but I think that what was interesting is that, first of all, we have new mechanisms of action, and second, for the mechanisms of action that we do have already, so we see what happens in the long-term outcomes. Silvio Danese was talking about the outcomes of the ustekinumab versus adalimumab CView pharmacokinetics. So as you remember, ustekinumab was not superior to adalimumab in the CView study, but they were trying now to look at the pharmacokinetics and the drug levels and immunogenicity and trying to see whether there was a correlation. And there was a correlation more with the endoscopic rather than the clinical outcomes. And of course, Laurent presented also the ustekinumab, the long-term extension of the Stardust, showing us that in patients that responded to ustekinumab, you had a long-term effect that was sustainable. So I think that is, of course, a terrible run-through because I didn't really want to take the whole day until tomorrow. But of course, you should watch that session and rank it as a 5-star because this is the bread and butter of how we treat and will treat our patients.
So Iris, it's amazing what is going on, I have to say. And I want to ask you, still the impression that in ulcerative colitis we have more studies. Why is that?
So I think that after many years of quote-unquote neglecting ulcerative colitis and thinking, perhaps because Crohn's disease is very heterogeneous, looks very difficult to treat, and people started to understand that, first of all, ulcerative colitis has similar burden, and we see that, and actually in this UEG also, you have reports on that. So this is one. And B, of course, it's very easy to sample it, so you can have biomarker sorting studies, and we have a huge unmet need. And actually, you're pitching to what I chose from the original abstracts, and those were studies that were focusing on ulcerative colitis with the unmet needs that we have there. So it was the MASK study, so a surgical study. I will let the surgeons be represented here today. No surgeon among us today. So Matteo Ferson was discussing the MASK study, looking at patients with severe colitis that were operated and underwent proctocolectomy, trying to look in an observational study, what were the predictors of their not responding to therapy. And interestingly, in addition to, suspected, I guess, risk factors like being hospitalized previously for ulcerative colitis, a previous appendectomy was found as a risk factor for not responding to therapy, something that we should take into account when we're dealing with appendectomy in ulcerative colitis. So that was, I think, very interesting.
Julia, did you have a question there?
Well, my question would be, as a non-IBD person, do you think we are on our way to a steroid-free treatment? So you mentioned the JAK inhibitors, There are more JAK inhibitors. Yes, they do have side effects, but do you think we still need steroids?
Still need, of course. We do need them specifically in the severe cases. But I think that you're highlighting a very good point. We're definitely aiming to be without steroids because we see the side effects, we see the long-term side effects, and I think we're making a huge effort to avoid steroids and to find what is good and relevant and, of course, cost-effective from the other medications that we have. And in this, we also had Marietta Ayacucci, of course, present a very small, so it was 29, I think, patients with ulcerative colitis, and their response to anti-TNFs. Mm-hmm. So they were trying to do molecular endoscopy and actually to see if the anti-TNF resides in the mucosa and to take biopsies and meticulously analyze them and see what are the molecular predictors for response to anti-TNF. So I found that very interesting. They also identified new pathways specifically related to chemokines, CXCL6. Again, you need to see these abstracts, to watch them, of course, to read through and see how it is presented, to know the details, because the details, of course, are important. But I found these two original studies very nice. And of course, we had wonderful invited presentations. We had the STRIDE 2, that's a must also, right? Also a must for 5-star. This was a wonderful discussion. Severine Vermeer and Axel Dignas, of course, led it. And Irit Avni from our center wonderfully, of course, in an unbiased way, presented transmural healing in Crohn's disease, which was not a target in STRIDE 2 in patients with IBD, but definitely should be considered. She presented it, and Laurent Perrine-Biroulet, of course, discussed our ambitions beyond STRIDE 2. And Kay Greverson, the IBD patient and nurse, provided such a nice overview of the patient way of looking at how we treat our patients. So I think that this was very well received. So this was important. There was a metabolite and diet wonderful talk by Lihi Godni, and of course Florian Reeder discussing fibrosis. So many things were yesterday. So thank you, first of all, Jonathan and Herbert, for letting me summarize Monday, which was, of course, was a wonderful day until Tuesday will be over. But I think there are so many new things, and I think that this is what I found fascinating, that I learned so much, right? We were in the field for quite a few years. I learned so much, so many new things, so many important things, and like you said, Julia, things that will probably characterize our future.
Game changer.
Yeah, I think that, and strategy changes. I think that strategy changes. So you'll have a hard job as the head of the scientific committee to choose what is best for next year. But I'm sure it will be great.
I have tons of experts helping me, so luckily it's not all relying on me.
So Iris, I mean, Julia was making a very important point, corticosteroids. I just remember I recently had a young patient. I mean, we did everything, but still he developed corticosteroid-induced osteoporosis. So it's still a big issue. And now with the more drugs, and you mentioned initially, I mean, not only JAK inhibitors, but also others, ABX and so on. So how do you see the near future, mainly using oral drugs in UC?
I think that oral drugs are coming back, and I think that what we will try to do is, first of all, find which oral drug, so many new mechanisms, many new drugs, but in the end of the day, you have to treat your patient with one drug, but then perhaps combine, start and stop. I think that this is one of the highlights of the small molecules. They enable you to have no immunogenicity, start and stop strategies, combination strategies. So I think that it's going to be very interesting and challenging. Not good biomarkers until now.
But we're having a lot of drugs now in hand, and what we learned yesterday, they work quickly, which I think is also a very important aspect.
Yeah. I should have mentioned that this goes throughout UEG now, how fast these molecules work.
A final question, you mentioned colectomy. So you mentioned the study now. So what's your personal judgment? How many patients at the moment will need colectomy? Can you make an
So I think that definitely the numbers are going down. You see, coming from population studies and also from the large centers, you see that the need for colectomy goes down. It will never be, of course, zero, because you have to, and there are some patients until today that have severe colitis, and of course the ones with dysplasias, despite our advances in endoscopy. So definitely those will still need colectomy.
Final short one for you.
No, it's not a final short one. It's just I take over from you, because I think regarding your question, there has been one abstract I wanted to highlight, and that's pretty interesting because yes, you're totally right. The number of colectomies are going down, but there is a very nice population-based study from the Netherlands, and they investigated 6,000 colectomies in ulcerative colitis patients over the last 3 decades. And if you and we all know that the risk of colorectal cancer in those patients after 10 years in the disease is 2%, and then it becomes 8% after 20 years, and then 18% after 30 years. And when you looked at these colectomy resection specimens, then in the first decade, when they got resected, the colorectal cancer rate was 11%. And then it increased to 16%. So remember, those are not the patients who are in their disease course for 20 years. So then it's 16%. And now, in the last decade, it became 22%. And that tells us that probably symptom control is much better. Patients don't have the need to get a colectomy for say, failure of the medication, but there's an increasing risk of cancer. So we really need to work on our surveillance strategies in this, in line with improving our therapy. And I think that's something I am taking home to my clinical practice from UEG Week.
Yeah, I mean, this remains a big challenge. And of course, we also have data that with better anti-inflammatory therapies, cancer will go down. But we have to remain very careful in this setting, I believe.
Well, I mean, it's 1 in 5. 1 in 5 suffering from colorectal cancer, and as this is not the Vogelstein way of cancer development in ulcerative colitis, it's very important to be aware of these relatively high rate in an industrialized country.
I absolutely agree, and definitely we should improve our surveillance programs, right? It's good that we have better endoscopies, better artificial intelligence, perhaps, approaches. So I think this is also an important highlight that was also discussed this year in UEG, but the abstract is extremely important. I agree with you.
Well, Julia, you eased into your recommendations from the highlights very well, very professional. What else did you like from yesterday?
Well, I mean, I decided that this morning I'd like to focus a little bit on oncology and leave out the pancreas, which is my usual field and a field of expertise. But I think oncology is moving on, and one of the important fields at UEG this year was the question about biomarkers. I mean, everybody's talking about personalized medicine, how we actually stratify our patients into the right treatment. And I think I'd like to start with some, say, very important concepts. And so if we identify biomarkers, and there are tons of abstract dealing with biomarkers in multiple cancers, then the most important thing to me is we have to validate them. And if you go through the literature, even in oncology, and we will need them for IBD and all other cancers as well, if you identify a biomarker, please validate them. And that sounds pretty simple, but it's a big problem. So if we come to the field of oncology, then FDA has approved currently 3 different biomarkers for cancer therapy. And that is MSI, PD-L1, and tumor mutational burden. So we need those for checkpoint inhibitor therapy. We have awarded the Nobel Prize. It's a very important point for us, so that's important. FDA approved the biomarkers. EMA will never approve a biomarker. We only approve therapies, and they're in conjunction with a biomarker. And that is something which is also pretty important, because this is when we know exact treatment recommendation for each of the cancers. So they are important studies, and these we have to know, and it makes it much more complex for an oncologist in Europe to apply the treatment.
Are you arguing that we need to validate the biomarkers?
Well, I don't know what's the better way, but it's just as a treating clinician, you need to be aware of the different situation in your country to provide the best treatment to your patient.
And as UEG heads, probably there needs to be approaches to policymakers, right, in the European Union to address that.
Yeah, and also we have to understand the microenvironment of the tumor, because there are biomarkers which you have to measure in the tumor cells, but we recognize, especially for the immune-based therapies, that it's not the tumor-based score which is important, but the composition in the tumor, so the CPS. And I come to that to a minute, and I mean, I'm now referring to the talk by Jean-François Emile, who spoke about biomarkers, and it was a really nice session. You should probably look at it. And then Julien Taillep went on, and he was highlighting what is the status of the immune therapy currently in GI cancer. And I mean, to me, it was a real, it's a real advancement in the field that we have now a therapy in colorectal cancer, even first line, in those patients who are MSI, so microsatellite instable, that in those you can just by pembrolizumab, you can achieve the same outcome than with a triple chemotherapy.
Wow.
So that's something which is, it's not without side effects. So that is what patients usually believe. There are tons of side effects, but however, it's very efficient. Yeah. And we've also learned that it's safe to use 2 checkpoint inhibitors like ipilimumab and nivolumab and combine them. And then in a second line treatment, we get an over response rate of 60%. Which is quite a lot and really a big achievement for the patient. However, I think you have to turn the argument around. They're still 40% not responding, and they are still microsatellite unstable. So because that's the selective marker and the selection marker. But then again, if you look at that, you have to work on, and this is why I chose that for this morning session. We have to work on the reasons. So one thing would be that we again need a score. So MSI in addition, and a score like PD-L1 expression or something novel. And for example, one really exciting field here might be microbiota composition. If you think about colorectal cancer, tons of bacteria interacting with the epithelial barrier. And then one responding, one not responding, it could be microbiota composition, which is influencing there. Also, what I like very much are those neoadjuvant concepts. I mean, in some, if your tumor is small and MSI unstable, and you respond perfectly, then we might not need surgery in colorectal cancer. So, which is something which is, yes, it's on the horizon, and it will take us years to actually get there, but it's a pretty interesting concept. So colorectal cancer is key for CPI treatment, but we've also made advantage for esophageal cancer. And this is an interesting story from a scientific point of view to me, because the first trials were positive, but they were phase 2 trials. And then there were 3 phase 3 trials, and we all know about how expensive a phase 3 trial is, and they were negative. But still, we pressed on with biomarker stratification and learned that in those where we have a CPS score, so remember PD-L1 being expressed in microbiota, is then it starts to really work. And we also learned that we can use the checkpoint inhibitors in conjunction with the conventional chemotherapy, which is also pretty beneficial, and it's increasing overall survival and progression-free survival in those patients. So I think that's...
Sorry to interrupt you. I just want to let you know you can get your questions in for this faculty, because it's a fascinating conversation. I'm sure there's people out there who are sitting back, but if you have a question for faculty, please do put it into the Q&A tool. Sorry to interrupt you in mid-flow.
No problem. I've got
I want to remind people, because there's some really interesting... I have some questions, but I didn't want to interrupt you.
Herbert has some questions as well. I'm happy to take questions. Well, I mean, it's all about discussing and not
you
about...
first and then I.
Well, actually, it was about something that Iris had said about the appendectomy having an effect on outcomes, and I was wondering, is that common in GI disease, that an appendectomy would have an effect on outcomes?
So less so, I think, in cancer diseases, but in ulcerative colitis and in Crohn's disease, we're very intrigued with the appendix, a very small organ, but probably with important immune-modifying abilities. So I think that this is why the interest came into that. I think it's less related to the...
We don't know. I mean, I just highlighted microbiota, but why not? Nobody ever looked at whether a person after an appendectomy reacts differently to a checkpoint immune therapy. I don't know.
It's definitely an important aspect, but what I wanted to ask you about the checkpoint inhibitor, and I always say we go first for the efficacy, that's true. But however, with the checkpoint inhibitor, colitis and side effects, and with all the advanced, were you intrigued, or were you thinking to yourself, okay, do we need to address also the side effects and how to handle them? Not to avoid the therapy because of that, but just to be ready for that and what to do.
So what I learned, I mean, I think it's good that as a gastroenterologist we have a relatively broad education, because the concepts of ulcerative colitis and treatment of ulcerative colitis need to be transferred. So, for example, in checkpoint inhibitor-induced colitis, it's very good to very early start biologic treatment. So don't stay very long with high-dose steroids, but vedolizumab, even if I don't understand the mechanism whatsoever, it works very good. I don't understand why, but it does. So it's infliximab and then vedolizumab, what we need, and we need to know about that even as an oncologist. And therefore, I think the organ-based oncological treatment provided by gastroenterologists and not only by medical oncologists is something which is important for the benefit of our patients.
And even last year we had a contribution here from Holland showing that when you use anti-inflammatory therapies in those patients receiving immunotherapies, there is no disadvantage. They feel better, but the tumor response remains very well. One question, microbiome. I mean, tumor microbiome is so important now in all GI tumors. So as you are aware, there are a lot of studies now running with FMT, plus minus immunotherapy. This is exciting. I mean, hopefully we'll see those studies presented here, because we are now in the learning phase, maybe the next 1 or 2 years, where we'll see microbiome targeting could be attractive and important in immunotherapy in GI cancers.
It's also quite interesting to see that. Well, I don't want to have that misunderstood, but it's the patient whom we actually study very closely, like what we try to do in cnotobiotic mice, to understand what are the drivers, the key players, and whom should we address. So it's exciting times.
Okay, Wafa has been waiting patiently. I'm very glued to this conversation, I can see. Wafa, how are you? You well?
Yeah, thank you.
Good.
It was a very, very exciting conversation.
Yeah. So please, if you wouldn't mind, tell us your highlights from yesterday as you watched from home.
Yeah, thank you. Actually, I made a really broad overview of what happened yesterday about endoscopy. And actually, it was a pretty intense day because there were more than 16 sessions dealing with endoscopy. And I just sum it up in upper GI, ERCP-EOS, lower GI, and other very interesting topics that were discussed yesterday. And in upper GI, Barrett's has been the talk in 3 sessions yesterday, and to sum all those sessions up in terms of biomarkers, and that's a good actually a way to follow up after what Julia said. Rebecca Fitzgerald said that for now, P53 is the only biomarker that is really validated and stand out in comparison with other biomarkers, and it could be used in immunochemistry in Barrett's to diagnose, to add actually value to diagnosis of dysplasia. Other multiplex biomarkers actually predictive tests are in development, but not yet in clinical practice. And for an endoscopy point of view, the cytosponge and what's brush 3D are already available now, and they can add some value into a diagnosis in the screening setting, but also maybe in the future in the surveillance setting. It's not necessarily used. It's not used actually with endoscopy. It can be used without endoscopy in this wrap up about endoscopy. And in terms of artificial intelligence, there were really intense discussions throughout the day. But in terms of Barrett esophagus, it's not the future actually is now, because there is a CE certified system that is already available to help assist endoscopists to detect Barrett and to assess the risk of neoplasia on a Barrett mucosa. And there is really interesting technical evolution in terms of 3D reconstruction of the old Barrett mucosa to help actually plan probably the strategy for therapy. And there is also some ESD, artificial intelligence ESD assisted for really bulky lesions and difficult procedures that outlines really nicely the vascular patterns and also the mucosa layer. And afterwards, there was a very intense debate and rising up the controversies about which actually endoscopic therapy to use in Barrett, EMR, ESD, and to sum all the discussion up, because it was in 3 sessions. Actually, EMR is safe, is easy to use, and is certainly easy to learn. Compared with the ESD that has really high performances in terms of R0 resection and en-bloc resection and very interesting oncological results. But in ESD, the adverse events were mainly strictures. And in that matter, to prevent actually strictures after ESD in Barrett, there was some nice data about maybe injection steroids in the site. But Pierre Després, at the end of the day, focused on the fact that it has to be really cautious. Endoscopists have to be really cautious while applying that. It has to be really small amounts, different points of injection, and definitely be away from the areas where the muscle layer is breached. And in terms of comparison and which technique to use, there is no standards for now, but definitely patient selection has to be defined. And ESD could be preferred in terms of bulkier lesions to have an en-bloc resection better than EMR. And EMR plus RFA probably is gonna be the standard for high-grade dysplasia and really superficial lesions. In terms of upper GI resection, there was really interesting abstracts about resecting endoscopical resection of esophageal neoplasia in portal hypertension. And you know how this population is difficult, and the bleeding risk was supposed to be really high. But there was a French and Belgian very interesting study, including 101 ESDs and 30 EMRs in those superficial esophageal neoplasia in portal hypertension patients. 71 of them had varices and 15 had large varices. In terms of severity of disease, MELD score was median 10 and mostly child A patients. So the outcomes in terms of technical success, it was really high. In terms of macroscopic resection, it was 92%, but in terms of R0, it was 63%. But the main point here is adverse events. Actually, they experienced just one case of bleeding in this series. It's important to mention that most of patients had prevention of bleeding prior, whether it is with lung band ligation or beta blockers or vasoactive drugs. But in this population, there was just one case of bleeding that was treated with tips. But the main adverse events was stricter, actually, mostly in the ESD group. And certainly when the incision circumference would mean circumference with 80% of circumference. Other adverse events were perforation in 3 patients treated with the 2 TTS hemoclips and 1 stent. And other adverse events were the compensation of cirrhosis in 6 patients and sepsis in 8 patients. But it showed nicely that it was a safe procedure in this population, difficult population to treat. Another abstract from Japan showing...
Herbert here has a question.
Just, Wafa, this is probably very important because you know all the discussions with the patients with portal hypertension, and once in a while we say, well, no surgery is too dangerous, so we do not give the patient maybe the proper therapy because we are afraid of. So when we now see the endoscopic approach is doing rather well, and this is a very optimistic study, then maybe this could change our approach to this type of patient.
I think so. It was showing nicely that it was a safe procedure, actually. And the population is very large, 100 ESD, 101 ESD. It's pretty representative, actually, of the safety of the technique, probably.
Very interesting.
And a Japanese paper, a Japanese abstract actually about a novel technique to close up the mucosal defects in ESD and gastric ESD showed, it's called Eloc, and they used it on 50 patients. And actually what was interesting in this technique is that they used it on a population under antithrombotic therapy to prevent the delayed bleeding. And they used actually regular endoscopes, gastroscopes with the working challenge 2.8, and they used devices that we all have in our endoscopy room, a hemoclips, a nylon loop, forceps, and band ligation, all together to close up nicely the defects. And the mean size was 30 millimeters. And actually, the prevention of delayed bleeding was really effective. They had only 1% of minor bleeding in this technique. It's called Eloc. It's probably nice to watch to see how it works. Other abstracts about resection in upper endoscopy were really interesting. ESD in neuroendocrine tumors and gastric neuroendocrine tumors. The debate there was type 3, very aggressive tumors. Is it really safe to resect with ESD? Probably there is a small group of patients that can benefit from that when they are not fit for surgery. For another resection abstract for upper GI neoplasia, it was interesting to see for a small subepithelial lesions, a group tried to band ligate those lesions and leave them without resecting them. And they had interesting results, but there was a great debate about the pathological specimen and how to prove that the resection was complete, etc. And in terms of upper GI, there were really interesting discussions about upper GI bleeding. And there was a very nice expert session discussion and also abstracts in that matter. And in terms of, to sum it up, in terms of variceal bleeding, there was no breakthrough. In terms of non-variceal bleeding, Ian Granek did a really good job summarizing EHGE guidelines that were published in March 2021. And the main point that I wanted to report here is that timing for emergency endoscopy, as he said, the sweet spot was between 15 to 24 hours. And it was showed in the data that doing and performing endoscopy in emergency setting really early, before 6 hours, was associated with worse outcome. So the timing is probably more after 12 hours and not really as early as 6 hours. And in terms of technical hemostasis, endoscopic hemostasis, OTCS, so over-the-scope clips, are a very good first-line therapy for bleeding, for non-variceal bleeding, and it is actually mentioned in the guidelines. And there was a very interesting abstract about that in the morning, about OTCS in 100 patients in a really high-risk acute bleeding or non-variceal bleeding in GI. Upper GI, and it was really successful in a lot of etiologies, 100% success, but not in all etiologies. Mainly,
Wafa, sorry, I didn't mean to interrupt you there. I thought you just finished that point. I know Julia had a question, and we have a question from our audience as well. Julia.
Wafa, I was just wondering, watching the program from yesterday, what do you think about this novel technique of endoscopic intermuscular dissection? So that you go, it's no longer ESD, submucosal, but you already we go into the muscle. So is that something which you believe is very attractive?
And also to address perhaps the closer and closer interaction or merging with the surgical professionals.
Absolutely, and there is combined actually procedures, endoscopy and surgery, to resect efficiently the whole actually layer of the mass of the wall. It's called full thickness resections, and they are really applied for now to small submucosal maybe lesions to have a curative resection of those lesions, and the results are really good. There was a very interesting talk from Professor Philip Shu in the afternoon in the expert encore that encouraged everybody to watch to see how those techniques are going to change definitely our practice in the future.
So what would be our ideas on how to evaluate the lymph node risk? Are there biomarkers for that? Is that something we need to study?
Yeah, definitely. Definitely, we need to study how is it curative oncologically, actually. But it is applied now for tumors that the lymph node risk is low. So it's not really widespread for all types of GI neoplasia. And definitely the adjunction of surgical procedures is definitely important in this matter to assess the lymph node risk.
We just have 1 minute left, and we've been asking the audience for their questions, and so I do want to get them. Herbert, there's a question there about esophageal varices.
Yeah, it was just again commenting that one attendee said, interesting, I used the fear of ESD in esophageal varices due to cirrhosis, but you answered with this study, there is hope for interventional strategies. And also, maybe a comment from my side, I'm in emergency endoscopy, that's very important what you said, and that we keep now those guidelines in daily practice in Europe. We have time, so prepare the patient very well and then do the procedure. That's the key message, isn't it?
Yeah. And actually, with the development of those techniques in endoscopy, the sky is not the limit anymore. Everything is possible. So how to imply them in a very therapeutic strategy, actually, that's the main point, Ram. That's the challenge, actually, how to use them. And they were really interesting, also abstracts. I'll move quickly to the enteroscopy because there was,
if you can make it really, really quick, if you can, because I do want to get to Henriette. Okay, thanks.
Okay, we had really abstracts about enteroscopy, and it was impressive how effective it is. A motorized spiral enteroscopy achieving pan-enteroscopy in 75% of patients, and it takes only 70 minutes. So it was really impressive results, and there were really interesting abstracts also about ERCP and difficult cannulation, and ESD and EUS drainages for distal CBD obstructions with the choledochoduodenostomy that is safe and effective, and gallbladder drainage also that was effective, and safety was debated. And also there was a really nice talk about quality in endoscopy, and I encourage you to see this session on recordings because it was really interesting talks. And the main point is that we have to raise the quality of training in endoscopy.
Wafa, thank you very much for that and for getting through that so quickly. Henriette, can we have your highlights from yesterday, please?
So, I'm used that neurogastroenterology comes down the line, and I want to thank Wafa for giving me a few talking points as well. I had a great day yesterday in my chairing cubicle. You have to imagine you sit in a little room in front of a computer and you see brilliant young researchers, you have brilliant discussions, and you think in the beginning when you enter that cubicle, this is going to be a long, hard day. But you look at your watch and you realize you've been there 4 hours and you've learned a lot. And I had a really good day covering motility and IBS because there has been insight into pathophysiology, how symptoms are generated, how patients with motility disorders can be recognized, and how they can be treated. And this is something that I find very encouraging because in my clinical practice, usually it's very hard to tell patients, well, you have those symptoms, we did all those tests, but honestly, we can't really tell you what's wrong. But yesterday, I'm not a basic scientist, but I was thrilled to be chairing an abstract from Dr. Ustaoglu from London, who investigated esophageal biopsies of patients with reflux disease and different subtypes of reflux disease, especially patients with functional heartburn. That means those patients suffer from heartburn, but when you objectively measure whether they have reflux, they have normal episodes but feel them. So it's very difficult to treat those patients because there's not a pathologic reflux that you can basically treat with PPI. And she found out that in those patients, the amount of dendritic cells, so cells that communicate with nerves, is elevated and they're further up on the surface, which means that this could explain how those nerves get sensitized and that those patients feel more. And that was something which really encouraged me, and she was able to translate this complex research in a very simple way so that a clinician like me could understand it, and I will be able to tell my patients this mechanism. And this is something that is very important in functional GI disease, where we only have only so far have symptomatic treatments to make the pathophysiology graspable for those patients. And this is really something that impressed me a lot, and I'm going to be looking forward to the next work out of this lab, because that was very brilliantly done. And then,
that's great, because we see that we now receive fantastic translational science at UEG, and combination with basic science, and bring this to the benefit of the patient. I think that's the reason we are here, and very nice example. Thank you.
I was so impressed, because usually basic science, I really have to stand on my toes, and it was so graspable, and it was such a good concept, and I will take this home with me to my patients with functional heartburn. And then, other functional diseases. There are some odd diseases which are often overlooked. Rumination syndrome. Does any one of you know what that is?
Absolutely. Why do you say that?
Cows do it.
Can you suggest a therapy for us after you've been all day yesterday with the abstracts in the neurogastro?
For rumination,
yes,
deep breathing. Deep breathing and no alcohol. No.
Yeah, the deep breathing and the...
But rumination is something that cows do. They have 7 stomachs, and they need to transfer their stomach contents in between their stomachs in order to make it smaller. In humans, this is also a phenomenon when patients suffer from abdominal pain or bloating, and try to subconsciously alleviate that by pressing food contents into their esophagus and into their mouth. And it's very often confused with reflux disease. And it's usually then refractory to PPI treatment. And there was a very interesting survey study from Dr. Josefsson, who surveyed with a Rome 4 criteria survey 54,000 patients, and he had a large number also rumination patients, and the incidence was worldwide 3.1%. That's larger than in the literature that's out there. And I think it's important to highlight that this can be assessed via questionnaire, because it increases the awareness of physicians for that easily to treat syndrome, because it's basically a physiotherapy. You have to have a good physiotherapist who teaches diaphragmatical breathing and relaxation to the patient. And I think this is really, really important knowledge to have, that if you have a patient with therapy refractory GERD, then you need to think whether this could be something different.
Things like that are usually ignored by doctors, or not well.
I'm not sure if it's ignored, but you usually realize that this patient might be behaving weirdly, but it's important to be aware that it's young women, higher BMI, low quality of life, high usage of clinical care, that you need to be aware if they're having reflux symptoms and they just don't improve no matter what you do. Before you do a fundoplication, or even go into that, do a manometry and give them a test meal and watch what they do. Sometimes they even do it while they're speaking to you, swallowing air and burping it up. So it's really a very intuitive diagnosis, and this is why I absolutely like that study, because it's something that you can see if you know it.
And you can treat it in a very sophisticated way,
definitely.
but it's very helpful.
Yes. So that was one of my highlights. And then to my favorite topic, achalasia. So there was a really nice study by Professor Penagini investigating post-treatment achalasia. And there's always the question, how do you see whether these patients have been treated sufficiently? Do you just go via symptoms, or do you need to perform a time barium swallow, which is radiation in those often young patients, or can you perform a manometry? And he very nicely showed in a large cohort of patients with low symptoms that the integrated relaxation pressure, so the integrated relaxation pressure of relaxation of the lower GI sphincter, if it's below 10, then you're fine. It corresponds with good emptying on the time barium swallow. So you can spare the patients the radiation by performing a manometry, which is not as, it's for the patient maybe not as agreeable, but it doesn't have radiation. So this was it's a really good clinical practical tool for physicians dealing with achalasia, that they can actually, with a rapid swallowing test, determine whether their treatment has been successful.
But I mean, I totally agree that probably manometry can be used. But let's be frank, if you look out in our GI community, how many colleagues are able to evaluate and do a good manometry? And how easy is it to tick the box and send somebody to radiology for the barium swallow?
I completely agree with you. Patients, usually when they've been with you a long time, they are not as opposed to the manometry, but just sending them for time barium swallow is the easy solution. But what I would say to that is the achalasia is not done when it's treated. It's a progressive disease, and you will have a certain probability that it returns or that it gets worse. So there will be a lot of time barium swallows. There will be a lot of imaging. And in these young patients, I think we just need to be aware that there are other options to treat them. But I agree, high-res manometry is not available everywhere. But if you have it, you should do it because it gives you lots of other information as well.
Bessie.
And then the last topic.
May I ask you,
Yes.
achalasia, BOEM?
Yes.
I mean, we heard yesterday gastric BOEM,
Yeah.
gastroparesis, very exciting. BOEM is in all minds, so BOEM for everyone at the moment?
That is a very difficult
With
question.
achalasia. Yeah.
So there are some people who would say yes, but I think it's a question of expertise. If you have an excellent surgeon and not an excellent interventional endoscopist, then you should consider surgery. But if you are in an interdisciplinary center, you can tailor the therapy to the patient. We all go for POEMs at the moment. It's a very attractive therapy also for the patients because they don't have a scar. It feels very intuitive to them that you say, we're performing an endoscopy, we're making a little cup, we're making a tunnel, we're cutting the muscle, you're fine. But theirs was a really nice poster abstract from Prague looking at the 6-year follow-up of those POEMs patients. And they all did quite well. So more than 60% had, after 6 years, were in remission, but 50% had reflux. That was managed solely with PPI. They didn't have any reflux complication. That's the price. But the research now points into the direction that you don't limit yourself either way, that the two treatments, POEMs and HeLa, they can be, an incomplete helomyotomy can be finished by the endoscopist and vice versa. And you can also add a wrap should reflux after POEMs become a problem. So I think interdisciplinary management and knowledge about what benefits and what downsides are important in this issue. And I think POEMs is an attractive option, but you need to select your patients and you need to ask your patients if they're ready to take PPI their whole life. So,
but there is still a place also for balloon dilatation.
There is a good place for balloon dilatation. I think it's usually when these patients come, they want a quick fix. And some patients really prefer to have balloon dilatation, even if it's every 6 months. So it can be a patient-tailored approach.
You have 1 minute.
1 minute, so I'm going to say something about education.
Yes, please.
So the last session that I had yesterday was the Rising Star session. And it was really interesting to see 2 young surgeons and an endoscopist talk about training and their passion about their respective field. And the talk by Giovanni Marchiani especially I especially enjoyed because he told us how to become a pancreatologist. And it was basically a blue pause, or why he became a pancreatologist. And it was a blue pause for any discipline in GI to work interdisciplinary with your pathologist, your radiologist, with your surgeon, with your rheumatologist, to really build an excellent interconnected network for patient care. And he also made some really good suggestions how to include that into education. And I think this is something that I think the GI trainees need to be aware of, that it's good to have your pathologist of trust and your radiologist of trust, and that you understand a little bit their language. And this is, I think, something that UEG will help to implement, that interdisciplinary discussion of patients for patient treatment benefit. And this is what I took away from that session, which I really much enjoyed.
I have a feeling that we might see implementation of some of these ideas over the next few years, Henrietta. Herbert, a great session, lots of interesting ideas. What is your quick highlights from yesterday?
Well, we had, when we started on Saturday night, expectations from people attending. They said, well, what do we expect? Well, several said microbiome-related research, and yesterday we had a very nice session on advances in microbiome technologies in IVD, IVS with great speakers. So I think hopefully we fulfilled those expectations because we really pushed the topic in the program.
Yeah, very interesting. Thank you very much for watching at home, and thank you, of course, to our fantastic on-site faculty, Dr. Henriette Heinrich, Julia Meyer and Iris Dotan. Thank you very much. And from Morocco, Wafa Kanoussi, thank you very much for your contribution as well, Chair Professor Herbert Tielk. We will be back in studio for Case Closed, where we'll be looking at more curious cases at 12. At 3 p.m. is Gut Talks Lessons Learned at 3 p.m. And then at 5:30, a best of UEG Week, including all of the UEG leadership live on stage as we have a few surprises in store for you then. So do join us there. Check out the My UEG Community Program Hall, where I'll be interviewing Elena Cortez Pinto, the incoming president of UEG, on her recipe for success in just over an hour. And CME certificates are available from this evening onwards. They can be downloaded when you fill out the evaluation form. See how we did that there? Don't miss out on your opportunity to earn 24 CME credit points for taking part in UEG Week. We'll be back at 12. Have a great morning. Thanks, guys. That was really good.